Thank you, Dr. Marashi. Very nice introduction. And thank you, organization, for inviting me uh, to present my cases in evaluation in the management of newly diagnosed transplant ineligible patients. So good evening, ladies and gentlemen. In next 15 minutes, in same contents, I will show you how we face challenges and what we have solution in 2022 by using the guidelines of NCCN, International Myeloma Group, ESMO, and CCO guideline, to how we implement the uses of some principles. So when we start, how do you choose the frontline treatment for multiple myeloma management? Which guideline you use? Treat hematology. So everybody use almost all these 4 guidelines, and we use actually NCCN guideline, and sometimes we use CCO expert online to decide which treatment should be given. So if we go NCCN guideline, this is my frontline therapy for non-transplant eligible patient. You have now tons of options. You have preferred regimen, Lendex, Dara Lendex. You have other regimens, KRD and Dara based 2 other regimens. Then in useful circumstances, you have VRD and VRD light. So this creates a problem that how do you choose? This is the challenge 1. And so it means multiple myeloma have multiple challenges despite of multiple novel agents. The important thing is how do we sequence the therapies to ensure the best outcome of patient in 2022 and 2023. So multiple myeloma is actually marathon to have long-term strategy. If you go by principles A, B, C, A means accurate diagnosis, and B means before beginning treatment, and C means check the indication. Check which chemotherapy suits. So you have to identify what is your target, big line or small animal. It means you have to stratify the patient. Here I made 5 type of the category. Category 1 is like standard risk, and category 2 is the orange line, which is like the patient lost to follow up. And category 3 is very high risk and ultra risk, like red line. And category 4 is very easy to treat the patient, green line. And category 5 is actually you have here, you can see thin line patient, which is actually very fragile patient to how to treat. So I have all these category type of patient. But important thing, as I mentioned, the burning question of 2022 is in newly diagnosed multiple myeloma, should we use our treatment first or save for later? The question is better to use chemotherapy first and daratumumab-based regimen should be in subsequent treatment, or should we use as a frontline therapy? As we learn in myeloma gets harder to treat if relapse, so it's better. The smart decision is to get the drug decision to get a longer PFS to use better the sooner. So by using same principle A to G, I will start my patient. So first patient is actually 78-year-old male who developed backache 3 weeks ago. Then he presented to us with some other history of 2 months following to different hospitals. And finally, he found a lytic lesion in the scapula. So when he came in our clinic, we checked his beta-2 macroglobin, and LDH was high, albumin was low. And the bone marrow that was compatible with the myeloma typical, and fish is hyperdiploid cryotype. So diagnosis as accurate diagnosis, IgG kappa multiple myeloma, revised ISS stage 3 standard risk category. So he has feature of the treatment. The first question, as I mentioned, C means check the transplant eligibility. Naturally, he's not transplant eligible patient. So what we do, what is the best treatment option for this patient? As my topic is evaluation of the treatment, it has gone from MP, then Lendex, then RVD, then Dara Lendex. So what is the drug decision should be taken in this patient? If you go by NCCN guideline, you have these 4 regimens. First, triplet-based chemotherapy, then new IRD-based chemotherapy, then Dara-based chemotherapy. The question is who goes first? Then you go through the 4 guidelines, all 4 guidelines. If you can see, NCCN says Dara-based and RVD-based chemotherapy. International Myeloma Group says also you can go to Dara RDR, VRD-based chemotherapy, and then ESMO is same. The important thing is here is expert online. I put the data of this patient. You can say 60% say 80% rather than they say DARA Lendex is the first line of therapy should be given in this patient. So you have now here DARA Lendex-based chemotherapy, which is again the MAIA-based chemotherapy, the same here we use in this patient. Here you can appreciate the patient after giving first cycle, the patient become pain-free, and after fourth cycle is almost a complete response of the M protein, and the patient is ongoing treatment of this one. So this is first patient of 2020. Now, if we go back historically in 2017, what we used to do, it was actually again 78-year female who came to us with history of anemia and lytic lesion, comorbidity with asthma, and performance status is 1, and confirmed multiple myeloma based on the bone marrow. Here you can see high beta-2 microglobin, high LDH, and low albumin with a high light chain kappa. And the diagnosis was made IgG kappa, light chain multiple myeloma, ISS stage 3, and standard risk. So again, all guidelines says, again, same DARA now in 2022, but we were in 2027. So what we did use in SABORD first, and then after PFS of 2, then we use VRD, then PFS of 2 years, then finally we reach to the DARA Lendex. So this is the profile of the patient. You can see first he was given SABORD, and then VRD for again 2 years PFS. Then finally the patient is currently on the DRD-based chemistry. So this is, I wanted to show you first patient in the beginning, and then this patient as a third line was given. Now, orange line, which I mentioned, last to follow-up of the patient. 68-year male, known asthma, having normal cytogenetics, confirmed multiple myeloma diagnosed. And again, in this patient here, you can see VRD was given for 8 cycles, then patient went lenalidomide, then last to follow-up. Orange line, as I mentioned, last to follow-up. After 1 year, the patient came with very high bulk of the disease, and the patient was confirmed, and we started, actually initially our plan was Kender-based chemotherapy, but the patient was not able, the last to follow means he didn't also accept to admit the patient for DARA-based chemotherapy. So the patient was given KD-based, Endure-based chemotherapy. So he went for KD-based chemotherapy 1.5 years. But again, the patients here you can see, this one, the disease again progress after KD-based chemotherapy, and the patient, the compliance problem, as I told you, very difficult patient. In this patient, actually, now currently I have chosen only 1 cycle is received PCB, PC means POMA, cyclophosphamide, dexamethasone therapy. POMA 2 milligram, cyclo is 50, and dexamethasone each week 20 milligram. So he is doing great. Now, case 4 is again red line, patient 67-year male, retired, and he has high risk of the disease, and he was found high LDH and beta-2 microglobin, and this is the cytogenetics and FISH of the patient, and the patient was diagnosed IgG kappa, multiple myeloma, high risk standard. So again, if you go by NCCN, in the guideline 2022. So the best thing is patients should be given the DARA-RD-based chemotherapy. But what we do here, this should be the standard here in 2022. But in that time, actually in 2021, we used to give again VRD-based chemotherapy. And here you can see VRD was given, but after 3 cycles, the patient's disease progressed. So then we started again Kender-based chemotherapy, DARA-KD-based chemotherapy. But despite of this, here you say the patient's bone compressions and all the symptoms are increased. So now what we have option, again, as I mentioned, there is 5th line, we call it the thin line. The patient, actually, the quality of life was also disturbed because of this chemotherapy, and he couldn't tolerate more than this. So again, very low type of chemotherapy, PCDB, again, POMA and cyclo and dexamethasone, again, low dose of chemotherapy. Over the 1 year, he is taking this chemotherapy. Now he's feeling, if you say quality of life, based on the PCD, he is doing much better than first 2 lines of the therapy. So here I want to emphasize to choose the patient, which patient should be given which therapy. Now, this patient, I would say maroon color is very dark. Why dark? The red color. This patient is 65-year male who has all the bad things in his disease. He had extramedullary disease. He had plasma cell leukemia, very high cytogenetics, ultra high risk patient. But patient is not, he couldn't go for transplant, other things. So patient was given even first VRD after 4 cycle, disease progress, then POMA, KD. He enjoyed good period of PFS, and again disease progress. Then he was given DARA KD with chemotherapy, and currently even DARA KD with chemotherapy disease progress. We have not options so more. So I just added cyclophosphamide. So over the 6 years, even you can see very ultra high risk disease, but he is doing great with the multiple novel agents. So there are some patients who really don't need such treatment. Like this is 72-year female who has renal dysfunction, who has multiple comorbidity, who has very low profile of disease. You can say almost equal to smoldering disease. So I just started VD-based chemotherapy, even 50% dose. And here you can say 5-year profile of the patient. Initially, she was given full weekly dose of the 1 year. Then every 2 weekly, she is doing great with the VD-based chemotherapy over the 5 years. So this is called green line type of the patient. So what we learned, the DARA should be given the first in this, like now in 2022, the most recent patient, we use this patient, 72-year lady, again, high-risk patient. In this patient actually given MAB-based chemotherapy after 4 cycles. She has a very good response. And this is just recently, last month, actually, I picked the patient, 70-year lady, who has very extensive disease and stage 3, with a high beta to macroglobin, LDH, and low albumin. And the important thing, the patient was so sick. He has acute kidney injury, hypercalcemia, and initially when she came, she has very high symptoms of the hypercalcemia. She was started with all the things which we use for hypercalcemia, calcitonin, denosumab, and finally she improved, and we started again this DARA Lendex-based chemotherapy just recently. Here you can see the first X-ray, which was here. She has also multiple pathological fracture, which was more in the humerus and radius. This was the X-ray in the beginning. Now you can appreciate only just 1 cycle. Today I've seen the patient. After 1 cycle, the patients, you can see how she responds, her profile, and she is much better quality of life and the chemical as well. So what I wanted to emphasize here over the last 10 to 15 minutes, that choose the multiple myeloma differently in different patient, as multiple myeloma is not a one disease and multiple myeloma is a marathon. So long-term strategy, choose whether the patient wants to fit in the green line, blue line, red line, orange line, or thin line, which I mentioned. You can give low dose of the some oral chemotherapy. So these are the patients which I mentioned. So in the last 15 minutes, I have gone through the eye opener, how I treat multiple myeloma. I showed the cases, and should we use our best treatment first or save for later. You can see in my cases as well how to implement all the trial which Dr. Kumar has mentioned. I have used almost all trials in my patients, and how to redefine the multiple myeloma. We can use all the resources to solve the challenges, NCCN guideline, expert online, ESMO guideline, and international myeloma group. You can solve the problem. Thank you very much. I'm here to answer any question. Thank you.